talk about sleep and comfort. So, what is sleep? Sleep is going to be a cyclical physiological process that alters with longer periods of wakefulness. So, we have what we call a circadian rhythm, and that's a 24-hour day night cycle that regulates our sleep and wake patterns. It's controlled by the hypothalamus, and then a really strong external cue that we have is the light outside. Any type of sleep or circadian rhythm disruption can impact the safety, learning, and health of that individual. So think of those people that are working, say, a swing shift or a night shift, or those that have been maybe traveling and they have jet lag. So sleep can actually affect a wide range of biological and behavioral functions, including but not limited to sleep-wake cycles, blood or body temperature, hormone secretion, mood and cognitive performance, and metabolism. So then we have stages of sleep. So there are several stages of sleep, technically four. Sleep is going to be divided between your non-REM or NREM, which is your non-rapid eye movement stage, and your REM or rapid eye movement sleep. And so a full cycle of this is about 90 to 110 minutes, and it repeats about 4 to 6 times every night. So the cycle that you go through happens 4 to 6 times. So first you start with your non-REM stage one, aka N1. And this is what's considered a light sleep. So this is when we're transitioning from that wakefulness to sleep. It lasts only for a few minutes. Your muscles start to relax, your breathing starts to slow down, and you are usually pretty easily awakened. You may experience, or the patient may experience, like this hypnic jerk or that sensation of falling, and that would be during that non-REM stage one. Then you have your non-REM stage two or N2. That's going to be a more deeper relaxation. So this accounts for about 50% of total sleep. The body is going to continue to slow down. So think like decreased heart rate, temperature, respirations. And at this time, it's going to be harder for you to wake them up than in stage one. And then you get to your deep sleep. Your deep sleep is considered the non-REM stage 3 or N3. That's going to be your deepest stage of non-REM sleep. At this point, that's when we will consider this like the start of restorative sleep. So when tissue growth occurs, cell repair occurs as well. At this point, your blood pressure, heart rate, respirs, those are all going to be at their lowest. At this time, you're also going to have difficulty awakening an individual, and if they are woken up, they may have some grogginess. This is also when sleepwalking, night terrors, and bedwetting would occur. Then lastly, you have your REM sleep, and that's your rapid eye movement stage. And this occurs typically around 90 minutes after falling asleep. It's going to be characterized by rapid eye movement, so it's in the name, rapid eye movement, vivid dreaming, irregular breathing and heart rate, and then also some temporary muscle paralysis, except for the diaphragm because you still are breathing, and your eyes because it is rapid eye movement in your REM sleep. This is very essential for us to be able to consolidate our memory, help with learning and retaining information, and our emotional regulation. And then next you have restorative sleep. So restorative sleep is often going to be referred to stages non-REM stage 3 and your REM sleep. This is the stage that allows the body and mind to recover, repair, and rejuvenate. So with your non-stage 3 and your REM sleep, it is going to help support physical, cognitive, and emotional recovery. Again, like I said in the previous slide, this is the point that you're going to have the lowest heart rate, respirations, and blood pressure. You're going to have increase in tissue growth and cell repair. There will be release of growth hormone, strengthening of the immune function, and memory consolidation and learning is going to occur specifically in that REM sleep. So, why do we need to have restorative sleep? Why does this matter? So, it's going to help with the physical restoration, like we talked about the muscle and tissue repair, immune system strengthening, and then it also helps provide some energy and it's going to regulate the metabolism and hormones in your body. It also is going to have that cognitive and emotional restoration. So it's going to help us organize our memories, process new information, and continue to learn, and then that emotional regulation. So when restorative sleep is poor, so when we're not getting those stages of sleep, we're going to be experiencing or witnessing in our patients fatigue, impaired healing, decreased memory and focus, an altered mood or irritability, increased risk of illness, and some safety concerns. Think of, we don't want somebody driving while they're drowsy. They could fall asleep behind the wheel. Medication errors could happen in the hospital setting if nurses are not getting that appropriate sleep. So then sleep requirements by different age groups. So first year your neonates, that's 0 to 3 months. Typically they need to have 16, 18 hours a day. Sleep is very fragmented and they are frequently awaking for feedings. There's really no established circadian rhythm at this time, and they're in about 50% of their sleep, they're in REM. Infants, so a little bit older, 4 to 11 months, they need about 12 to 15 hours a day. Usually that's 9 to 11 hours at night, and then they have naps throughout the day. And this is when they're going to start to develop a more regular sleep wake pattern to get to like a quote unquote normal sleep. At this point, they'll have about 30% of their sleep be in REM. And then you get to toddlers. Toddlers considered 1 to 2 years of age, and they typically have 11 to 12 hours a day of sleep. At this point, they usually still have one daytime nap, and they will have some increased independence. Toddlers are independent little creatures. Like my boys are very, especially at toddler age, they can be resistant to bedtime. So because of that increase in independence in our toddler years and in the toddlers, if we see kiddos in the hospital, they may resist that bedtime. That's very common and kind of expected developmentally. You then have preschoolers, so that's considered 3 to 5 years of age. They need about 10 to 12 hours a day of sleep. At this age range, when kids are going to start to transition away from naps and they're just going to be sleeping fully at night, just like an adult would. And at this time, also in our preschool age kiddos, that is when nighttime fears and nightmares may start to occur. Then we jump into school age kiddos. That is between 6 and 12 years of age. They need about 9 to 12 hours of sleep. Sleep is really still high in demand, just like the younger ages, because it's needed for the growth and learning. One thing that can hinder or reduce their amount of sleep or quality of sleep is screen time. And then maybe they have some demanding schedules. So think your school age kids, they might start to get involved in sports or school activities. And that leads to maybe they're not going to bed until later because they're not getting home till, 8 or 9 o'clock because they had a baseball game. This next, it goes into adolescence. That's going to be considered 13 to 18 years of age. They need about 8 to 10 hours a day is what's recommended, but most adolescents usually only get about 7 hours. This is when we start to see a shift in the circadian rhythm. They call it like a sleep phase delay. And they're also at a high risk for chronic sleep deprivation due to school activities, the utilization of technology. So we want to avoid technology before bed. Lack of sleep in adolescence can really lead to difficulty concentrating in school, a declined academic performance, slower reaction time, hence that they are more prone to accidents. It'll also be linked with irritability and mood swings, impaired judgment and decision making. A lot of times they're going to be more impulsive and have a higher risk of utilizing substances when they have that lack of sleep. All right, then we get into our adults. So young adults classified 18 to 35 years of age, they need about 6 to 8.5 hours of sleep a night. Typically good sleep quality. it occurs, but it could be a struggle if they have work and school schedules, if they're balancing any stress, if they have kiddos at home. Sometimes lifestyle factors like social activities or screen time are going to be a hindrance on their sleep. We do want to just encourage healthy sleeping habits and consistent routines, which we'll talk about here in a little bit. And your young adults are typically in REM about 20% of the time. You then have middle-aged adults, that's 36 to 64. They need about 7 to 9 hours a night, same requirement, but their sleep quality is actually going to start to decline. Common influences are going to be life stressors, their career, being a parent, being maybe a caregiver to their parents or a family member. There's also going to be some health changes that may occur, like weight gain, hypertension, menopause. Menopause is a big one that we see a shift in their sleep. And this is when insomnia, nighttime awakenings, or sleep apnea becomes a little bit more prevalent. And then you have your older adults at 65 or older. They should get about 7 to 8 hours of sleep, but sleep really becomes lighter with more frequent awakenings. So they have a decrease in their REM and deep sleep, which is that N3 phase or non-REM 3. Common issues that occur at this age range is also nocturia, chronic pain, medication side effects, depending on what medications are on, maybe an increase in restless leg syndrome and sleep apnea. At this time, their circadian rhythm shifts a little bit, and so they usually have an earlier bedtime and then they wake up earlier as well, and that's fairly normal for this age. So then you have a few different sleep disorders. So first you have insomnia. That's going to be your most common sleep disorder. That is the difficulty falling asleep, staying asleep, or waking up too early. It can be acute, like a short-term concern, or it could potentially even be chronic. Some factors that may contribute to insomnia are stress, poor sleep hygiene, medical conditions, and certain medications. Symptoms of somebody that has insomnia, they're typically going to have daytime fatigue, irritability, and decreased concentration. So our biggest focus as a nurse is to make sure that we provide adequate education on sleep hygiene, relaxation techniques, and some cognitive behavioral strategies as well. Then you have sleep apnea. So sleep apnea is characterized by repeated episodes of breathing cessation during sleep. So there's two types. You have obstructive sleep apnea, which is OSA, and central sleep apnea. So obstructive sleep apnea, the airway is going to collapse or there's a blockage, whereas central sleep apnea, the brain is actually failing to signal respiratory muscles. Some signs and symptoms of sleep apnea are going to be loud snoring, witnessed episodes of apnea, daytime sleepiness, morning headaches. Also, a risk factor for individuals for obstructive sleep apnea is hypertension, obesity, heart disease. We also measure neck circumference, and anything greater than 18 centimeters on, especially a male, 17 centimeters on a female, is going to increase their risk of getting obstructive sleep apnea. You next have narcolepsy. That's a disorder of the central nervous system causing sudden, uncontrollable sleep episodes. So these symptoms, a patient may come in, have excessive daytime sleepiness. They may have like sudden muscle weakness, which is called cataplexy, or sleep paralysis, maybe some hallucinations. Typically, narcolepsy is going to start or onset in adolescence or young adulthood. As a nurse, we need to make sure that that patient is safe, they're adhering to their medications, which is typically going to be a stimulant of some sort, and that if they do, they have scheduled naps no greater than 20 minutes a time. You have parasomnias, that's undesirable behaviors that occur during sleep or sleep-wake transitions. So this think sleepwalking, night terrors, bedwetting, maybe acting out their dreams, so like a REM sleep behavior disorder. And as nurses, again, we just really need to maintain that safety, reduce stress. Another common one is also restless leg syndrome. It's an uncomfortable sensation in the legs with an urge to kind of move. It's typically going to be worse at night or at rest, and it may be linked with maybe an iron deficiency or chronic condition. So what are some factors influencing sleep? So first, we need to think of like any physical illness, if they're in pain or discomfort. If there's any respiratory disorders like asthma and COPD, that's going to affect sleep. Any cardiac conditions, think like congestive heart failure, it's then going to be difficult for them to breathe. Nocturia, GERD, chronic illness like diabetes, arthritis. Certain medications or substances are also going to affect sleep. So think your stimulants like caffeine, nicotine, and then there are some antidepressants that can affect sleep. Some depressants such as alcohol, that's actually going to disrupt REM sleep, and we need REM sleep, so it's not good to drink alcohol before going to bed or at nighttime. Medications, also think of beta blockers, decongestants, steroids that can all alter sleep. And then sleep aids, so medications that we give for sleep, can actually alter normal architecture, like in our brain, for sleep, and that could be harmful if taken like long term. Lifestyle wise, are they exercising? Exercise is going to help promote sleep when done earlier, but if it's done too late and it's overstimulating, it can actually stimulate and cause decreased sleep. Looking at their daily routines. Is there a shift in work or irregular schedules? What's the individual's electronic device use before bed? Emotional stress can also play a factor, like worrying, anxiety, depression. And then your environment. So, what's the noise and light situation like? What's the temperature? If it's too hot or too cold, that's going to disrupt sleep. The bed comfort, sleeping with a partner or pets. And then you also have diet. Diet, so if someone's eating something heavy or like a spicy meal before bedtime, that's going to decrease their quality of sleep. Same with if they're intaking caffeine, like coffee, tea, or chocolate. Alcohol close to bedtime, like we already discussed, that would not be beneficial. And then hunger in general can disrupt sleep as well. Smoking, again, smoking or nicotine is a stimulant. So we definitely want to avoid that before bed. And typically, your individuals that are smokers, they have a lighter sleep ability. So they're light sleepers and they may have like withdrawal during the night while they're sleeping, and that would cause them to wake up and then go smoke. Age can also be a factor because sleep patterns do change with age. And then as you get older, and especially in your older adults, you're going to have less deep sleep. And then, of course, like we talked about, those sleep disorders, that's going to influence your sleep as well. So what are some assessment cues for sleep? So we want to gather that sleep history. So what is their, chief or main sleep concern? Is it difficulty falling asleep? Is it frequent wakenings? We want to get onset and duration of the issue, previous sleep problems or treatments for those sleep problems, and then do they utilize any sleep aid? So whether that's prescription medication, over the counter, or herbal. We want to assess their usual sleep patterns. So when's their typical bedtime? When do they typically wake up? Time it takes to fall asleep, the number and duration of nighttime wakenings, any napping patterns, etc. And then, of course, the physical issues affecting sleep, like we just talked about in that last slide, psychological issues as well, and current life concerns. When you get down to emotional and mental status, sleep can affect our mood. So irritability and impatience can occur. Altered concentration or attention. We cognitively will start to slow down. And then we always do want to ask about like bedtime routines and sleep environment when going to bed. Before you go to sleep, are you on your phone? Are you looking at a screen? Are you reading a book? Are you eating food? Like what is happening right before you fall asleep? And then what's that sleep environment like? What's the noise, temperature, light level? Is the mattress pillow comfortable? Are you sharing a bed with a partner? And then, behaviors of sleep deprivation is kind of all the things that we just talked about. They're going to have daytime sleepiness, falling asleep unintentionally, like during class, while they're watching TV, sometimes even while they're driving, reduced attention span, impaired memory or decision making, slow reaction time, mood swings, or irritability. So then on the physical exam side, some general physical cues that we want to look out for is, do we notice that they're fatigued or have a low energy? Are there any dark circles under their eyes? Are they yawning frequently? Are they falling asleep during conversation or the exam? And poor posture or slumped appearance. So one, we want to look at that airway and structure. Um, these cues suggest a risk for sleep apnea or impaired airway during sleep. So if they have receding jaw, a small jaw structure, enlarged tonsils, large or thick tongue, high arched palate, smaller upper airway size, deviated septum, those are all factors that it can play into this. Same with the neck assessment. Like I said, it is typically, I think I said 18 inches or above in men and 16 inches or above in women for that neck circumference that would lead to wanting to look further into sleep apnea. Also looking at their body weight, body habitus, any cardiac issues or findings like hypertension, irregular heart rate, tachy or bradycardic, edema, signs of poor circulation oxygenation, that's cyanosis, pallor, cool extremities, low O2 saturations. So then we have some diagnostic tests and screening. So one of them is just keeping a sleep diary. So it's important to keep a sleep diary to report or record bedtimes, wake times, any awakenings, any naps, and really that perceived sleep quality. And then you have what we call a sleep study. And so the sleep study itself, that is called a polysomnography or a PSG. This is going to be your gold standard diagnostic test for sleep disorders. So it's conducted overnight in a lab. There are versions that individuals can do them at home. A lot of times they have that you do it at home, and then if that one does not come back appropriately or like invalid, then we would bring you into the office to have you do a sleep study. So what are we looking at during a sleep study? We're going to be looking at brain activity, eye movement, muscle activity, heart rate, respiratory rate, and oxygen saturation, and also like leg movement. Really going to help us diagnose obstructive or central sleep apnea, narcolepsy, parasomnias, and unexplained excessive daytime sleepiness. So then to promote health or sleep health, we want to first educate to maintain a consistent sleep schedule. Go to bed and wake up at the same time every day, even on the weekends. This can help regulate our circadian rhythm. And then create a sleep conductive environment, making sure the room is quiet, dark, and cool. Use comfortable bedding and supportive pillows. Reserve the bed for sleep and intimacy only. We also want to establish a relaxing bedtime routine. Enjoy, calming activities like reading, a warm bath, gentle scratching, or meditation, and avoid anything that's going to stimulate them. So, for instance, don't work right before bed. Any stressful discussions don't have before bed, and video games don't do right before bed. We also want to limit exposure to screens before bed. So there's this blue light that is emitted from screens, whether it's a phone, tablet, or computer, or even TV. We want to avoid those technology pieces for at least 1 hour before bedtime. That blue light that's being emitted off the device is going to suppress melatonin, and melatonin is that sleep hormone. You also want to monitor diet and hydration, avoid caffeine. Caffeine, remember, is in coffee, tea, energy drinks, any of those, and especially avoid that in the afternoon or evening. Limit alcohol, which can result in disruption of that REM sleep. Avoid heavy or spicy meals close to bedtime and stay hydrated, but limit foods right before bed to prevent nocturia. We do want to encourage physical activity and have regular moderate exercise, but we want to avoid vigorous exercise within 2 to 3 hours of bedtime. So these are just things nurses can do to help promote sleep. So really looking at their environmental controls, clustering our cares to provide periods of rest and sleep, promoting comfort, providing safety, any stress reduction, restorative or continuing care, so periods of rest and sleep, and decreasing that stress, maintaining their activity, controlling any physiological disturbances, and then those pharmacological approaches as well. What is comfort in nursing? Comfort refers to the state of physical ease, freedom of pain, and relaxation that contributes to restful sleep, recovery, and overall health. Nurses really do play a key role in assessing and promoting comfort. So, first, we have to think of our physical comfort, so pain management, positioning, any hygiene care, environmental adjustments. Whereas psychological and emotional comfort, where we're helping reduce stress, providing a calm environment, and getting patients involved. Comfort and sleep. We also want to provide interventions to promote restorative sleep by reducing pain, anxiety, and environmental distractors. And then some just other generalized nursing considerations is always making sure that we assess comfort regularly with our individuals and with our patients. And then we really want to make sure that we tailor any interventions completed to that individual, their needs, and their preferences. Here's a good aid of the different, or a visual aid of the different types of pain that you guys will need to know. So we have acute versus chronic pain. Acute pain is going to happen short term, usually less than 3 to 6 months, whereas chronic is long term, so greater than 3 to 6 months. Onset for acute pain is typically going to be sudden, often linked to an injury or illness. Chronic, though, is going to have a gradual or persistent feel, and it may follow an injury or have no clear cause. Um, in regards to the cause of an acute pain, it's typically going to be something that's identifiable, whether that's the patient had surgery, a trauma, infection. Whereas chronic, it's often unclear or ongoing. So think of arthritis, neuropathy, fibromyalgia. And then the purpose of acute is serves as a warning signal for tissue damage, whereas chronic, there's really no protective purpose, and it may cause functional impairment. Symptoms wise, for an acute pain, it's sharp, localized throbbing, may include some anxiety or agitation, where chronic is going to have a dull, aching, or burning sensation, may cause fatigue, depression, and sleep disturbances. Psychologically, in the acute pain, you're going to have a sympathetic activation. So that heart rate and blood pressure are going to go up. You're going to have some diaphoresis. Whereas in acute, you're going to have adaptation may occur and the vital signs are often normal. Treatment for acute pain would often be an analgesic, as this is the most responsive, where chronically requires multiple avenues of management of medications, physical therapy, psychological support. Prognosis for acute would be usually resolves with healing, whereas chronic, it can persist indefinitely. The goal is just the management, not the care. There are special types of pain. You have a chronic episodic pain that occurs sporadically over a period of time. The pain is going to kind of come and go, and it's going to be often unpredictable. Examples of this is a migraine headache, a sickle cell crisis. Nursing interventions make sure that we're assessing frequency, triggers, and duration of episodes, plan interventions for pain flare-ups, and educate patient on coping and early management. Cancer pain, this is going to be associated with a malignant disease. 90% of patients are also or are able to manage their pain effectively with proper treatment. So now we have somatic pain and visceral pain. So somatic pain is going to include your muscles, bones, joints, connective tissue, and skin. It's typically well localized and it's going to be described as a sharp, aching, or throbbing pain. So this is going to come from cuts, fractures, say arthritis, sprains, and there's typically minimal systemic symptoms with this. It can be acute or chronic pain. Visceral pain, that's going to be more, think internal organs, so your stomach, intestines, liver, pancreas. It's typically going to be poorly localized and it's going to feel squeezing, cramping, or pressure-like. Examples include appendicitis, an MI, gallbladder disease. Sometimes these individuals may have nausea, vomiting, diaphoresis, restlessness. And then often this is diffused and may be acute or chronic. So acute, think of like something is being obstructive, or chronic is liver disease. And then you have neuropathic pain. And you have two different types. You have centrally generated pain and peripheral. So centrally generated pain, that's pain originating from damage or dysfunction within the central nervous system. So think brain or spinal cord. So types, you have deafferentation pain, the loss of sensory input from a limb or body region. So think post-stroke, spinal cord injury. You also have phantom pain, which is pain perceived in a limb that has been amputated. You have sympathetically maintained pain, and that is pain maintained by the autonomic nervous system dysfunction. So a lot of times we think of complex regional pain syndrome. Characteristics are typically going to be burning, shooting, or stabbing sensation, and it may be associated with altered sensation as well. Nursing considerations is we always want to assess the pain intensity, any triggers and impact on function, monitor for any sleep disturbances or mood changes, and then you will utilize a multimodal pain management approach where you may be on anticonvulsants, antidepressants, include physical therapy or relaxation techniques. Peripheral generated pain, that's pain resulting from damage or dysfunction of the peripheral nerves. So you have painful nephropathies. I apologize about that. That is widespread peripheral nerve dysfunction. So think of diabetic neuropathy. You have painful mononeuropathies, and that's going to be single nerve involvement. So if you have like carpal tunnel syndrome. Then you have a nerve root compression, and that is when you have like a herniated disc causing radiculopathy. Characteristics typically are tingling, burning, stabbing, or numbness. It can be localized to specific dermatomes or peripheral nerve distributions. Often it's going to be worse at night and it's going to impact their sleep. So for us as a nurse, we want to monitor for functional impairments, fall risk and skin integrity, provide pain relief from with pharmacological agents and non-pharmacological interventions, and then educate patients on foot care, active pacing, and positioning. So what's the nurse's role in comfort? So again, comfort is a fundamental human need that affects physical, psychological, and emotional well-being. So nurses play a really critical role in assessing, promoting, and maintaining comfort. So the assessment of comfort, we want to evaluate in physical discomfort, with having pain, fatigue, nausea, dyspnea, or musculoskeletal strain. Assess emotional or psychological needs, identify environmental factors, and utilize standardized tools like the pain scale, anxiety scale, sleep assessment tools. Nursing interventions to promote comfort. What we can do is provide physical comfort, psychological, emotional comfort, environmental comfort through the things that we've already talked about. We do want to educate our patients and families on strategies to maintain comfort at home, advocate for interventions that reduce pain, anxiety, or environmental barriers, and support continuity of care and communicate patient comfort needs to the healthcare team. Factors that are going to influence pain. So pain is subjective and it is multidimensional. So there's various psychological, physiological, social, and cultural factors influencing a person's pain experience. So age can play a factor. Infant and older adults may perceive and express pain differently. Fatigue is going to increase their sensitivity to pain. Genetic predisposition sometimes can influence pain threshold and tolerance. Neurological function, nerve damage can alter pain perception, and health status. So chronic illness, acute injuries, or post-surgical conditions can change that influencing factors of pain. Do they have family and social support? The presence of supportive caregivers can actually reduce the perceived pain. What about attention and cultural norms? We do want to assess psychological factors such as anxiety and fear. That's going to amplify pain tolerance. Depression or stress can lower pain tolerance. Coping strategies, we do want to educate on those and previous pain experiences. So Do their previous experiences with pain influence expectations and reactions? Of course, environmental factors, cultural and spiritual factors, cognitive factors such as attention and distraction. Focusing on pain may really increase discomfort, whereas distractions can help. So with the pain assessment, we all know how to do a pain assessment. We want to make sure that we ask the patient to describe the pain, which is the characteristics of the pain, how is the pain affecting them, what's their tolerable level, determine their health literacy, obtain vital signs, utilize appropriate assessment tools. So over here on the picture on the right, you have your numeric pain rating scale. So if you say rate your pain on a scale of 0 to 10, 0 being no pain, 10 being the worst pain ever. And then you have your Wong-Baker Faces pain rating scale. And so that's going to be utilized more in your pediatric populations. You also want to assess for medications, environmental factors, and perform a physical exam. And then over here on the right-hand side is the characteristics of pain. So asking about the time, onset, duration, and pattern, location, severity, quality, any aggravating or precipitating factors, and relief measures that they've taken. So when do we reassess pain for oral and IV medications? So for oral medications, you would reassess 30 to 60 minutes after you've administered an oral pain management medication, whereas IV is going to work quicker. So you will assess 15 to 30 minutes after administering an IV pain medication. So next is taking some action. So we really want to help them have some independence. So we want to make sure that we have patient-centered approach when we're managing their pain. And then we do want to make sure that when we are providing effective pain management, that we're being patient and we're being flexible. Also, we always want to do the least invasive and always something that is safe therapeutically before we do something more invasive. Pharmacologically, for pain management, we can give analgesics. We have non-opioid analgesics, so acetaminophen, NSAIDs, that's used for mild to moderate pain. We do need to be aware of liver and GI toxicity. You have your opioid analgesics, that's morphine, hydromorphone, fentanyl, that's used for moderate to severe pain. With those medications, we want to monitor for sedation, respiratory depression, constipation, and dependence. And then adjunctive analgesics, so that's going to enhance pain relief or target specific types of pain. So example like anticonvulsants, gabapentin, antidepressants, and muscle relaxants can be given too. We also want to assess for the routes and types of analgesic deliveries. You can give oral, that's pretty convenient in the standard route. You also have patient-controlled analgesia, so your PCAs, that's going to allow the patient to self-administer controlled dosage of an opioid. You have topical and transdermal analgesics, local, perineural, and epidural analgesics as well. So with health promotion, we really want to help with non-pharmacological interventions that can enhance comfort, reduce pain perception, and improve overall wellness. So we want to teach our patients about relaxation techniques, so deep breathing, guided imagery, progressive muscle relaxation, anything to help with that pain management. Distraction is another good one, so shifting that focus away from the pain and instead doing maybe some social interaction, reading, a puzzle, watching TV or a movie. You can also do music therapy. It's listening to calm or preferred music that can help reduce anxiety and stress and the perceived pain intensity. You can also do cutaneous stimulation. So think massage, warm baths or compression, cold application, or even the transcutaneous electrical nerve stimulation or a TENS unit. That's going to help block the pain signals and stimulate endorphin release. You also have herbal and complementary approaches. So these are the different like herbal remedies or creams. We do want to educate them to be use these with caution and coordinate with their healthcare provider to avoid any interactions. We also want to reduce pain perception and reception. So if there is like a wet dressing or wet linens, we want to change those immediately to prevent any skin irritation or discomfort. We want to properly position our patients and utilize the correct lifting techniques. and ensure supportive pillows or devices for comfort are being utilized. So, what are some barriers to effective pain management? So, sometimes we have client barriers such as fear of addiction, worrying about side effects like nausea, constipation, sedation, or cognitive effects, inadequate education, fear of disease progression. Some patients believe if they're reporting pain, that may indicate worsening illness. Healthcare provider barriers, inadequate pain assessment, so we're not doing an appropriate pain assessment, or maybe have no pain management protocols or inconsistent approaches across providers on pain management. Healthcare providers may have concerns about addiction or accidental overdose with medications, and that can lead to the fear of legal repercussions. And then last, you have your healthcare system barriers. So concerns for creating addicts. A systemic caution may limit access. Difficulty filling prescriptions. So what's the pharmacy access? What's insurance coverage? Limitations on reimbursement for medications. Poor institutional policies or procedures. So this really like lack of clear pain management guidelines.